to introduce our speaker for this morning. And this is on the medical perspective of our conference theme. Dr. Halina Woroncow is a staff consultant and assistant professor of family medicine at the Mayo Clinic in Rochester, Minnesota, mother of 2 wonderful daughters, and an active member of Holy Anagade Greek Orthodox Church. She comes to medicine by the way of a music and Russian double major at Oberlin College, followed by several years with the Carnegie Endowment for International Peace in New York City. There, Halina uncovered an appreciation for medicine as a healing profession for her next step in life, and went on to complete her medical degree at Harvard Medical School, her residency at Mayo Clinic, and never left Minnesota, the long winters notwithstanding. Dr. Woroncow feels blessed to be able to care for patients from cradle to grave, from labor and delivery to the nursing home. She serves as medical director for Fairview Care Center in Dodge City, Minnesota, medical consultant for Dodge County Public Health, and core faculty for the Mayo Family Medicine Hospital Service, as well as supervisory staff at the Salvation Army Free Clinic in Rochester, Minnesota. Halina has participated on multiple medical missions, which have been tremendously rewarding and illuminating, and hopes to join OCMC in this capacity one day. She also serves as medical coordinator on the executive board of OCAMPR. Halina enjoys working with the multidisciplinary team that shapes her professional life, teaching budding physicians, and incorporating the basic tenets of her Orthodox faith in her work with patients. She is grateful for the opportunity that OCAMPR provides for us to recognize and appreciate the fact that science and faith are not mutually exclusive in the eyes of Orthodox Christians. Let's welcome Dr. Halina Woroncow.
Thank you for that wonderful welcome. Good morning, Your Grace, esteemed clergy, brothers and sisters in Christ. I hope you're enjoying the conference so far. Thank you to all the speakers and paper presenters and workshop organizers. I've heard a lot which resonated deeply in my own soul as a medical provider and helps me to reflect as an Orthodox Christian. At the risk of some overlap with some of the topics that we've already touched upon, my job today is to reflect on the theme of compliance and resistance from the medical perspective as a primary care physician, a family doctor, providing cradle-to-grave patient care for 28 years. I've delivered babies, shared difficult diagnoses, attended 50th wedding anniversaries. It's been an amazing gift, and it's an honor to stand before you today. Much of our contemporary Western society would be surprised to learn of a faith-based gathering at which a medical professional might participate. It's a postmodern world. There's a presupposition of a disconnect between science and religion. They cannot coexist. They're at odds almost by definition. One is rational and evidence-based. One cannot be proven. But my personal experience as a physician has only served to reinforce the coexistence and synergy of science and faith in my daily practice. My faith plays a major role in how I find empathy and a route to communicate with the angry patient with a difficult personality. My faith allows me to accept that certain unpredictable outcomes can only be explained by a greater power, which sometimes works despite my own best efforts. For me, OCAMPR has been the perfect synergistic environment within which to bathe in this holistic experience of my professional life. I can experience myself as an Orthodox medical doctor. Our OCAMPR theme this year is compliance and resistance, discerning the spirit. In medical science, we apply these terms to a variety of circumstances. Physiologically, compliance refers to the degree to which a part of the body might be either stiff or supple. Compliance is the ability of any compartment to expand to accommodate increased content. If a part of the body is less supple or compliant, it has more resistance. If blood vessels become stiff with age, for example, less distensible. It takes more pressure to move blood through the vessels and into the bodily tissues, and this contributes to the development of high blood pressure, among other physiological complications. The more compliant a blood vessel is, an artery specifically, the more effectively it's able to expand, to accommodate surges in blood flow, and distribute that flow maximally to bodily tissues. Our blood supplies oxygen and nutrients, an infection-fighting arsenal to our tissues, and it washes away waste and spent carbon dioxide. We need that perfusion to our tissues. When vessels become stiff with age or disease, compliance is reduced, and resistance to blood flow is increased. There's more turbulence, higher blood pressure, reduced blood distribution, and increased work of the heart. That in turn can negatively impact the long-term health and efficacy of the heart. So too much resistance is not an optimal state of affairs cardiovascularly. The heart itself can be too compliant or too resistant. A heartbeat has two phases: a relaxation phase, during which the heart must be compliant so that it can be filled maximally with blood, and an active phase, during which the heart muscle contracts in order to pump the blood through the blood vessels into the bodily tissues. A heart can be too muscular, too stiff, too resistant, and be unable to relax effectively in that first phase to allow for optimal filling and adequate blood flow. The patient's symptoms might be shortness of breath and fatigue. An enlarged heart from various disease processes is too compliant. It's baggy. The muscle is thin and it doesn't contract well. The heart can't generate enough force to effectively pump blood through the vessels and into the body. People again experience shortness of breath and fatigue. Our lungs also require a balance of compliance and resistance to work optimally. They need to be able to expand and let oxygen-rich air in, and then recoil to exhale the air from which oxygen has been extracted in order to start the process over again. In certain conditions, the lungs are too stiff. They can't expand. The person can't get enough air, enough oxygen into the body. The patient pants. He's short of breath. In other conditions, the lungs are too compliant. They lack recoil or resistance. They're like a plastic grocery bag. They can't expel the air well in order to restart the process of breathing. Those patients end up needing to use their chest muscles to help them exhale, to make up for that lack of recoil, that lack of resistance, if you will. They're fatigued simply trying to breathe. That's hard work, let alone trying to walk across the room or up the stairs. So it would seem, physiologically, that our bodies are made to strike a balance between compliance and resistance in order to function optimally. Too much of one or the other can compromise the performance of our organs and negatively impact our physical experience of life, our quality of life. Physicians talk about compliance and resistance in a less concrete way as well, and that is in relationship to our patients. My daughter, who's in pharmacy school, reminds me that the current politically correct nomenclature is patient adherence rather than compliance. Compliance comes off as paternalistic, 1950s. Don't ask questions, just do as I say. It's a connotation of submission to a presumably more knowledgeable power. I hear a little call for humility there. We'll explore that in just a minute. A non-compliant or non-adherent patient can get labeled, dismissed, like the boy who cried wolf. Sometimes there's an immovable characterological underpinning to the patient's stance, and that's a talk in and of itself, but that's not always present. Non-compliant patients appear to understand what's being asked of them, but they don't do it. They can be looked at as a drain on the system or a waste of time. They have frequent or missed office visits with no change in their clinical outcomes. We like to see the fruits of our labor. We like to think we can make a positive difference in each person we see. A physician's goal is to channel his or her knowledge and experience in the interest of lessening acute or chronic suffering or preventing it long term. The goal is to improve the patient's quality of life. When that evaluation and professional advice, when that offering is not embraced, when that patient-doctor exchange doesn't seem to click, we have to consider what might be getting in the way, both from the standpoint of the patient and the provider. What are the barriers to patient adherence to a recommended regimen? The treatment of hypertension, high blood pressure, is a perfect medical example for this discussion. People usually feel perfectly well when they're diagnosed. It's often an incidental finding in the office. They're here for foot pain or a rash, and the nurse takes their blood pressure according to the rooming protocol, and boom, they have high blood pressure, just like grandpa. Why should they treat something that doesn't seem to hurt them in any way and only has potential future implications? But I feel fine, doc. Why do I need a pill? One might experience a strong denial reaction to the diagnosis of a chronic disease. They don't want to consider something that won't go away like a sore throat would, but which they must embrace and treat, and due to which they need to change their behavior. The patient may not want to accept a diagnosis because it has implications for their future insurability. That's certainly a very real contemporary concern. Cost is relative, and in general, thankfully, we can treat most patients with high blood pressure medicines that are generic and no longer considered exorbitant in the pharmacology world. But any added cost is a financial burden for any given patient. And with some medicines, we need to do periodic blood tests to make sure that potential side effects are not occurring, additional cost implications. Do I pick up my meds or get my labs, or do I wait until I can pay for my rent? It takes time to treat a medical condition, time to come in for lab work or a visit with a dietitian, or to make an appointment for a recheck with the provider when time away from work can be difficult to come by. Any medication can produce side effects, potential side effects, even Tylenol. I've learned never to say never if a patient tells me that they're having some negative response to a medication, even if I can't find that particular side effect in a pharmacological database. It's that person's reality, regardless, whether that's physiologically driven or psychologically driven. What if we think we're treating a condition, we've signed prescriptions and ordered lab work, but the patient's not getting better? His or her blood pressure is still high. We, of course, should consider other physiologic reasons that it would be more difficult to manage the blood pressure. But we need to ask if the patient's actually taking the medication. One study reported that people who admit to missing any doses of a prescribed medication are typically taking fewer than 80% of prescribed doses. If we don't ask, and the patient doesn't admit that he or she's not filling their prescriptions, we might increase the dose of the pill when we see them next in the office. The blood pressure is still high, so we assume they need a higher dose of medication to control the problem. But then when they actually do take their medication at the increased dose, they become lightheaded with a blood pressure that's been driven too low. Or we add an additional, possibly unnecessary medication in hopes of better control, but we're actually adding further complexity and cost to the patient's care. Maybe more blood tests, certainly more office visits to try to confirm efficacy, to confirm that we have helped this patient. The attempt to treat can spiral in unnecessary directions. Or perhaps instead, we sit looking at scheduled office visits that go empty when the patient just decides not to show up anymore. Why don't patients just tell their doctors that they're not following instructions and not taking their medications or changing their diet or starting to exercise? Is it embarrassment, guilt, not wishing to disappoint, not wishing to admit to other difficulties in their lives? Or are we just not listening? Maybe our patient is like John, a fictional patient trying to navigate a complicated medical and personal life. John is described in Victor Montori's book, Why We Revolt. Dr. Montori is a Mayo Clinic endocrinologist and researcher who's done a lot of work in the arena of patient relationship and compliance. John is a 55-year-old man. He's overweight. He takes 2 different pills daily for diabetes. He also has hypertension, and until recently was using a diuretic, a so-called water pill. Because he was not meeting the target for blood pressure control set in the practice's contract, his doctor added another tablet, a beta blocker. Now, every time John stands up quickly, he becomes dizzy. John also has high cholesterol, depression, a painful lower back, and pain in his feet from damage to his nerves caused by diabetes. Because of lack of progress in improving any of these conditions, John's primary care clinician referred him to the big medical center. Her hope was that he'd get sorted out by a diabetes specialist, a podiatrist, and a dietitian. To attend these appointments, John had to take time off from work and convince his neighbor to give him a ride. In these visits, the doctors told him that he needed to avoid salt, fats, carbs, and he needed to be active and to exercise despite his painful back and feet, that he needed to check his feet regularly. But John has not been able to see his feet for some time because of his rather large belly. The doctors repeatedly admonished him for not taking his pills regularly, assuming that this must be why he was not meeting the disease targets, even though he does take them. That's exactly why he gets dizzy when he stands up. He did not get a chance to contradict them, though. They also told him to check his blood sugars and to log them, to write them down. He's been writing down his numbers religiously, bringing them to his appointments, but instead of reviewing the logged numbers, his doctors routinely focus on a laboratory measure of the average blood sugar levels in the last 3 months, known as the hemoglobin A1C. In all these encounters, clinicians only discuss John's inability to lower the levels of the A1C, his cholesterol, blood pressure, and weight. Not a word about John's difficulties with pain, insomnia, and despair. John was also worried about his job. He was at risk of a layoff, and if he were to lose his job, he'd also lose his ability to pay his debts and his health insurance premiums and his mortgage. He also had the recent occurrence of his older daughter coming back to live with him. When she showed up at the doorstep, she was seeking refuge from an abusive relationship for her and her 2 daughters. No escape seemed possible, however, from her addiction to painkillers. So compliance, adherence to medical recommendations could be influenced by a number of factors. Complicated lives with competing legitimate priorities, patients like John. Rushed office schedules with providers who don't review patient data even when they bring it in, or just don't really listen to the patient, as was just described. Inadequate patient understanding of the recommended treatment. Medical discussions can easily devolve into medicalese. If the patient just diagnosed with hypertension, high blood pressure, feels well, and they do until they have their heart attack or stroke, they may not understand why they must commit to a daily medication with its cost, need for monitoring, and side effects. We need to be able to take the time to explain to the patient at an appropriate lay level the rationale for treatment and the consequences of non-adherence to medical recommendations. It's our job to explain effectively how a medication should be administered, its effects and possible side effects, and what beneficial lifestyle changes are needed in conjunction with taking a pill. Cognitive barriers. The patient with reduced cognitive capacity due to congenital developmental conditions or dementia or traumatic brain injury may not be able to grasp the gravity of their diagnosis and adhere to a new routine necessary for their health. Denial. The patient feels well and doesn't accept something could be wrong. It makes them think about growing old, perhaps, about their mortality, and that's just not a comfortable topic. Financial concerns, the cost of medication, the cost of blood work and office visits, concerns about insurance coverage, meeting one's deductible, future insurability. The patient may suffer from depression, anxiety, chronic stress. It's difficult for them to care for themselves, so they're non-compliant with recommendations to improve their health. A person who's anxious may not comprehend the information clearly. They're already overwhelmed by life. We screen for depression and anxiety in the office, as this can influence just about any physical presentation as we try to assess as well as respond to treatment. Language barrier. We do use interpreters at Mayo as a standard of care, But this still complicates communication and our ability to get a true sense of how a patient might be accepting the news of a new diagnosis and their motivation to treat. The patient may use alcohol or other substances. Alcohol not only complicates the treatment of hypertension and depression, for example, even when the person is taking their medications, but the patient's personal priorities are not around managing a medical condition, but rather continue to focus on how to obtain their substance of choice reliably. That's a complicated topic in and of itself. The alcoholic is notoriously non-compliant and in denial not only of identified medical conditions, such as hypertension, but about their addiction and the physical, societal, and interpersonal sequelae of their continued alcohol use. There may be cultural barriers to accepting medical recommendation. I've had patients tell me that in their Hispanic culture, it's not acceptable to acknowledge depression as a condition to be treated. Instead, we might see that patient in the office frequently for a variety of unrelated physical complaints, without a forthright discussion about stress, depression, or anxiety. It's our challenge as medical care providers to identify and validate emotional distress as something worth treating and able to be treated while remaining sensitive to a patient's cultural milieu. We might find resistance to treatment recommendations based on the tenets of a person's religion. If they follow their doctrine, a faithful Jehovah's Witness will not accept blood products, even if they're experiencing a life-threatening hemorrhage. A Christian Scientist will look to prayer under the direction of an internally trained Christian Science practitioner for healing from a medical condition, rather than accepting advice from the medical establishment. The patient and provider may have different expectations of the visit. The patient with a cold who needs to travel in 2 days for a family reunion is hoping and expecting a magic bullet to cure their viral infection overnight. They really don't want to listen to an explanation of how viruses work and how antibiotics won't resolve their symptoms and likely only contribute to side effects or long-term harm. They're not getting the answer they wanted. They want to feel better now. That's our society, isn't it? Instant relief, instant gratification. But this provider is withholding a prescription from them. They might leave the room disappointed, angry, confused. Their cousin got an antibiotic for the same thing. They freely express their dissatisfaction with such a pointless visit. This patient has incomplete knowledge of the medical problem and arrives with presuppositions. He or she is resistant to the evaluation provided and will not adhere to the recommendations offered due to preconceived notions and expectations. The physician is faced with the quandary of compliance and resistance in this scenario as well. The physician can choose to be compliant with the patient's wishes and prescribe the antibiotic, even though it's not medically indicated, because it'll make the patient happy. And frankly, it'll make for a quicker, more pleasant visit. It takes much more time and energy to explain why an antibiotic is not useful for a cold and can actually do more harm. Do I resist the patient's agenda or comply, even if it's not consistent with my knowledge base and experience? Another example of expectation interfering with care, perhaps fueled by the practice of other prescribers, is the new patient who just moved to the area, who's on a long list of medications, which their new physician might not have ever chosen to start singly, let alone in combination, for reasons of safety and efficacy. The new patient expects to walk away continuing on their daily benzodiazepines and scheduled narcotics, and doesn't want to consider other investigations or treatment modalities for their symptoms. They become angry. They lodge a formal complaint to patient affairs about the insensitivity of their new doc. So it may be easier to comply with a patient's wishes, overlook accepted prescribing standards, than to resist and have to deal with extended discussion and documentation to close the loop on such an encounter, and have to deal with decreased patient satisfaction scores to boot. Yes, our professional test scores include patient satisfaction. To some degree, medical science has fueled the public expectation and desire for unnecessary antibiotics or unnecessary testing that wouldn't change the plan of management for a given condition. Everyone wants an MRI, but a minority of us actually need one. We all like state-of-the-art technology and to see what's going on in the crispest images possible. But today, good science and good stewardship of medical resources requires that we work to diffuse those expectations with compassionate listening and education. We need to find a common language in order to try to bring our patients relief in compassion, in love, even when underlying psychological issues might complicate that interaction. What about cases with an ethical undertone? The family member who's overly involved in the case of their father or mother, either to the benefit or detriment of the patient's care, requesting tests that won't change appropriate management for that elderly person with multiple, progressive, chronic conditions who's nearing the end of their life on earth, or insisting on hospitalization and refusing to leave the hospital even when no further inpatient treatment is appropriate or available. Or the negligent family member who won't accept and enact treatment regimens for the person for whom they're to be responsible, either out of ignorance or denial or financial concerns or malice. We sometimes need to go the difficult route of legal intervention to adjust that mismatch of compliance and resistance. So as medical care providers, we need to figure out what is preventing the patient from accepting good advice and caring for themselves. It can be a myriad of reasons, as we've discussed. It can be a belief in alternative treatments, or greater trust in Dr. Oz, or their next-door neighbor, than the board-certified physician whom they've come to see. How do we address that? How do we build trust? Patients are suspicious of the medical establishment. Doctors don't listen. They just want to make money. Drugs are bad. More drugs are better. Vaccines cause irreversible harm. We can refute some of these types of misconceptions with data and pamphlets, but how do we get to trust? The fact is that I, too, deep down believe that pharmaceutical and insurance companies are basically out to make a buck. The cost of generics, let alone new medication, is still quite high in many cases. And it seems that long gone are the days when the discovery of a medication or a vaccine is offered as a boon, a gift to humanity, rather than a moneymaker to be tweaked every so many years before the patent expires, to be renamed, reissued as the new brand name medication offered at full cost rather than at a generic discount. When Mayo Clinic scientists identified cortisone in the last century, a Nobel Prize-winning medication that's still extensively used today for a variety of sometimes life-threatening conditions, they sold the compound to Merck Pharmaceuticals for production and distribution to the public for $1. The medication continues to be remarkably inexpensive decades later. Drugs are expensive, but sometimes inescapable. Sometimes we need drugs to treat a medical problem. Physicians need to work thoughtfully and effectively as patient advocates in a world where pharmaceuticals and insurance is overpriced and possibly cost prohibitive. My patients need to trust that I'm prescribing only what is necessary and in a form that is cost-effective, safe, practical, and consistent with their worldview and the realities of their lives. My patients need to trust that I won't order unnecessary testing or withhold that MRI when it is necessary. My patients need to trust that I can assess and diagnose their symptoms more reliably than would a search on the internet. To generate trust, we need to be able to see the patient as an individual, as the image of Christ before us. Not just a fleeting appointment slot within a blur of cases in a busy schedule with just a few minutes to listen and to review a templated electronic record in which one needs to search deeply to differentiate one patient from another. It's easy to make assumptions about someone we've never met before. And it's easy to lose the humanity in the medical case before you. It's not uncommon to hear, "I'll go into the ear after and return to see the pneumonia when the chest x-ray's back." No, healthcare must remain a human activity. It's dangerously easy to lose track of the actual human person who's suffering in some way before you. They may be suffering in a way that's not clearly manifested, or which they're unable to reveal to begin with. One needs to draw on compassion in order to take the time to delicately explore, for example, whether an abusive relationship at home is what's causing your patient's insomnia. We need to walk with, suffer with our patients, as we heard in one of our paper presentations yesterday, not simply leave them with a prescription. We need to find the psychological and spiritual space to see each patient as the image of Christ before us, to try to understand and ease their burdens, show kindness, come to an effective and practical medical plan for their case, do shared decision-making. Guidelines and protocols are very much at the forefront of medical care these days. There's an algorithm for everything. The attempt is to standardize care so that medical management is not wildly different between different physicians, clinics, hospitals, states. But the danger is that we miss the patient while trying to dot our I's and check off all the boxes in stringently following all of the evidence-based rules. Again, the patient becomes a case, not an individual, with time or money constraints, or work issues, or elderly parents who need care, or a bad marriage, or other real competing priorities in life. I can do more harm than good by too stringently conforming to an algorithm. It's important that we continue to term these evidence-based recommendations and standards as guidelines for management. They should not substitute for individualization of care, for the best medical approach to a patient with his or her own unique set of circumstances. This brings to mind to me the orthodox concept of economia, a medical economia, if you will, the handling or managing of a circumstance with discretion in accordance with the person's unique context and medical needs and personal needs, not by following a medical canon of recommended procedures, but determining which path towards improving their health will contribute to the most productive therapeutic relationship, and ultimately, the healthiest outcome for the patient. In medical circles, sometimes we refer to this as the art of medicine. The model for clinical practice these days is shared decision-making, defined as an approach where clinicians and patients share the best available evidence when faced with the task of making decisions, and where patients are supported to consider options to achieve informed preferences. I think medical economia is part of good shared decision-making. So is the negotiating of compliance and resistance present on both sides of the medical therapeutic relationship, with humility and an acknowledgement of the role of free will in the process. I've always taught my residents in training that it takes humility to be a good doctor. We will never know all the answers, and we need to embrace that reality and be open to unexpected successes and failures. We need to step back and give the patient the space to tell us what they think or worry is going on and what they think they need to help themselves. Sometimes they're right, and our first plenary speaker spoke exactly to that point. And the patient needs to find the humility to accept a professional assessment that might be different from that which they expected to hear. And if they're unwilling to do so, we need to recognize that that patient is endowed with free will after all. While we leave the door open, should they change their minds, they do not have to follow our advice. The exchange between a physician and his or her patient is most effective if it's approached with empathy and mutual respect. The patient, whom we may be seeing for the first time, presents in vulnerability, with uncertainty. He's taking a risk in exposing himself, both physically and psychologically, to seek relief. There's a great disparity between the knowledge base of the patient and the provider. He's relying on the physician's competence, skills, integrity, and goodwill. And as one of our afternoon presenters indicated yesterday, We need to be grateful to our patients for entrusting themselves to us. In The Doctor-Patient Relationship by Susan Guild and Mac Lipkin, the authors note that this relationship is remarkable for its centrality during life-altering and meaningful times in a person's life, times of birth, death, severe illness, and healing. Thus, providing health care and being a doctor is a moral enterprise. An incompetent doctor is judged not merely to be a poor business person, but also morally blameworthy, having violated the trust that is an essential and moral feature of the doctor-patient relationship. The medical profession is a high calling, a moral calling, a spiritual calling on some level. But the foundation of the patient-doctor relationship is really not unlike any interpersonal relationship. It's really about recognizing and embracing the other as our brother or sister in Christ, with their own unique set of struggles and challenges in life, and responding in love with the gifts and talents that we have been given by God. The patron saints of my parish in Rochester, Minnesota are the Holy Inagiri, Saints Cosmas and Damien, also the patron saints of OCAMPR, the Holy Unmercenaries. How fitting. These twin brothers provided healing freely and prayerfully to the prince and the pauper alike, considering their abilities to be granted by God, for from the Most High comes healing. In chanting their Triparion, we beseech them to heal our infirmities. Freely you have received, freely give to us. They effected remarkable cures, miracles, which they understood that could have only occurred through divine power. For every good and perfect gift is from above, coming from you, the Father of lights. And these gifts are meant to be shared in love, in community. Truly, our faith in Christ, our Orthodox worldview, our call to love the other, to walk with them in this journey of life, is the vehicle through which we might best be able to discern the best avenue of healing for any given patient, and strike a balance when faced with a mismatch of compliance and resistance in the therapeutic relationship. Thank you.
We're open for questions. If you'd like to ask a question of Dr. Woroncow, if you come over to the microphone to my left, or I guess you can use this now, or does it matter? Okay, now you could come here.
And any personal experiences, because we had great presentations yesterday afternoon, so if anyone would like to share any thoughts from yesterday.
You know, I was thinking about the therapeutic relationships that were discussed yesterday and walking with and beside the other in that. But I think in the medical field, there's more of a power differential between the doctor and the patient than what seems to prevail more in the therapeutic field and the direction that that's taking. Could you address that a little bit in regard to, you know, how you share with the patient the care that they're going, you know, they help to make the decisions about their care. But again, with the doctor and the patient, when it comes to medical, physical things, it seems like there is more of a power differential that needs to be addressed too.
Mm-hmm. And it's, you know, I kind of refer to that mismatch in knowledge. It's like me talking to an IT guy or to the car person. I have no idea. I have to trust them. But I think it's our job to try to get a sense of the patient's educational level and speak at that level, and make sure that they're understanding what we're having to say. So not to rush through. Again, you need time for that. You need to know the patient. Sometimes, despite your best efforts, it's hard to get that across. But I agree that's a challenge, and we have to be sensitive to that and realize that the patient can only really engage in that decision if they understand enough to help make that decision.
Boy, Halina, that was great. So my question is, you brought up the issue of trust, and I feel this issue very intensely on a number of topics. Let me just give one example, and maybe you can give some advice on what can be done? So in Chicago, I recently dealt with an issue where a person who is not medically trained has decided that vaccines are dangerous, that we use embryonic stem cells for one vaccine in the US. Now all vaccines are bad. We should stop vaccinating everybody. I was trained as an immunologist. I've worked in immunology for, 30 years of my life? And my word about this, when I've studied it, I understand it, means nothing. Mm-hmm. But this person who has a PhD in English now talks about it, and suddenly people in the church are listening. Could you give some advice on how to deal with that? Because I'm very frustrated by it.
Yeah, and I think that falls to the patient will part of things, though, too, to the free will. Because all we can do is try to educate. If we try to push too hard, that's going to be pushback. That's not going to be useful. So gentle, persistent, knowing that the door is open, maybe raising questions gently. If we push the envelope too much, that door is going to be locked shut. Because that's how it approaches.
Thank you.
Thank you very much. I'm a chaplain, and I had a question for you. We have a lot of patients who are like the patient that you described, with a lot of different illnesses, a lot of social issues, psychological issues. And I hear what you're saying about being open to the fact that each person has their own unique set of circumstances, and we see Christ in that person. But there's also the part where there's a lot of feelings involved in dealing with a person, especially since so many of those people don't live. Because when they're not adherent, eventually many of them die. So we should talk to that, because many people here work with those patients, and there's a whole lot of set of feelings that'll go along with sadness with working with those patients.
So sadness around not being able to encourage them to take a route that could help them, you mean?
I think there's helplessness.
Yeah.
I think there's sadness based on the fact that there's a built relationship and you know that person is going to die. Certainly some frustration, as you mentioned. I just feel that we have to look at the fact that we have feelings about our patients also, and connection with them. And so, if you would speak to that a little bit.
Yeah, I'll try. If anyone has some experience with sort of, kind of grief counseling for caregivers is kind of what you're referring to. That would be an interesting topic sometime down the line. We can get attached to our patients like we can get attached to family members, friends, relatives. And in our presentations yesterday afternoon, there was discussion about how some folks feel that they have failed a patient, right? I mean, I'm here to cure you. If I don't cure you, if I don't lengthen your life, I've failed in my profession as my job in life. And I think, I guess for me, that's just internal work. And again, I'd be interested to hear from anybody who does kind of grief counseling. That's internal work that I need to accept that this was God's will, that this is to be. And I personally consider how I have tried to manage the case, anything that I might have done differently, sort of intellectually, professionally. And then it's a matter of accepting that this is God's will.
Hi. First of all, I'd love to have you for my family doctor.
This was not that cold.
Second of all, I'm a chaplain at Sloan Kettering. And I'm struck by two things listening to your talk. One is the isolation of the physician and thinking about this shared decision-making. I often think of it as my job is partly to run interference for doctors to help patients come to terms with treatment and prognosis. And I offer my services to staff as well as to patients. I'm aware of a kind of, I think of it as an internal bias that I see on the part of a lot of medical personnel, that if they need to talk to me or they need to ask me to talk to a patient, they have failed on some fundamental level. And my feeling is that I want you guys to be focused on the medical. And I'm there to help all of that run more smoothly and help the patient come to compliance. And also, the other part of my question is the compassion fatigue that everybody on a medical team goes through, and helping medical personnel be more open to that idea of getting help for compassion fatigue.
Yeah, that's a good topic that probably deserves time on its own. I am blessed to work in an environment where we approach patient care in a multidisciplinary fashion. So we expect a team of individuals. Every patient, when they're admitted to the hospital, is asked whether they'd like to see a chaplain, regardless of what the admission diagnosis is. So my medical environment, my practice environment is such that we understand the importance of a variety of specialists, professionals in helping the patient. It's just not a matter of which IV to place when and how often to give the medication. That's not what it's about. And so that helps to attend to some of the issues that you're talking about. I think, compassion fatigue. So what do? I try to, again, with my faith, I try to sit back and reorient myself as an Orthodox Christian. So that helps me. Not everybody maybe has that background. Again, thankfully where I practice, we are open with each other. We try to support each other. There is an avenue for, I don't know if I want to call it time off from work. So if someone is suffering some fatigue, they can actually take a leave of absence for a bit, hopefully come back refreshed. There's counseling that's available, so there is attention to that. But I think in many environments, the whole question of isolation is definitely an important thing to consider and work on. So thank you for bringing that forward.
And we only have 10 minutes left, so I think this will be all the questions we can take. Try to keep it quick.
First of all, thank you. That was so beautiful and holistic. You said holistic, you were holistic. Just wanted to add one thing. In terms of the sense of loss and defeat in the dying, I've also helped those in my arms who have passed away. But as Orthodox Christians, it is not our defeat, it is our victory. And it is very difficult because of the depth of grief and sorrow, whether they're our loved ones or ones we caregive to. But this language of you lost your battle with cancer, she lost her life, you were defeated, and my answer is no, it was their final victory.
Very nice.
Maybe better if you both just speak in both.
My father was a general practitioner and my mother was a Christian Scientist, so compliance was never an issue in our house. My father never made any recommendations to my two brothers and I. My mother was happy to comply with that. I might get the statistics wrong, but I think the research shows that by the time a patient gets to the parking lot after a medical consultation, they've forgotten about 50% of what the doctor said. And by the time they get home, they're complying with about 60% of what they remember. So part of this is a short-term memory issue. They did some really interesting research in Britain, where I used to live. They chopped off an average of 4 sessions of psychotherapy simply by doing one thing that was very clever. They recorded the sessions with the therapist and asked the client to listen to the tape when they got home. It's kind of like seeing a movie for the second time. You pick up so many things more that you didn't see the first time around. I have one patient who does this. She comes in with a digital recorder, and she records every session. And she goes home and listens to it, and she does make a lot of changes as a result of that. The other thing I wanted to bring up quickly was the work of Prochaska and Di Clemente. Years ago, they came out with a trans-theoretical model of change, which is very relevant to what we're talking about here. And basically, they said that our clients and patients go through a process of change, and if we get this wrong, we're going to give them a task that is not congruent with where they are. They talked about the pre-contemplation stage, the contemplation stage, preparation, action, maintenance, and termination. So we have to get that right if we want our clients to be compliant. Lastly, if I have a smoker or someone who wants to lose weight, I ask them to go to my website, barrybehart.com, and take the motivation test. It's 4 simple questions where they rate themselves on how motivated they are to change, because motivation to change is the best predictor we have of outcome with addictions. That's all I want to say.
Yeah, no, that's great. We try to give out pamphlets informationally to help people remember. I'll scribble things, I'll hand out things, but I mean, patients still need to read it in the aftermath. We have an electronic record, which is a blessing and a curse. So if the patients can access their electronic record, and presumably the information's in there. Now, it's not going to be the detail that we talked about because it's, you know, it's just kind of the Reader's Digest skeleton of what the discussion was. But we do have that available to patients as well to try to bridge that gap. That's a very good point.
Thank you so much. I was just reflecting on Burl and Cleo's questions, and the thought that flashed across my mind was there are days I wake up and I wish I was a car mechanic. Because cars don't fight back. They don't, you know, you figure out what you need to fix and you tweak it and you pull this off and you put something, you know, wouldn't it be nice? And so it's so difficult. If a person loves cars and loves mechanics, well, they're in control of that process. You can build a car from the ground up. You can fix whatever's broken on any given machine. It's really difficult to care for people who have autonomy. And you can share with them, you can give them spiritual direction, you can give them clinical advice, you can give them medical prescription, and they can look you right in the face and walk off and not do anything that you say. And it's, if I attach my well-being and worth to other people's compliance, man, I get so sore spiritually and emotionally, and even physically. I've left my office many a days with headaches, you know, that just were throb, and I know that I have somehow gotten too invested in the process and haven't been able to keep from attaching my worth to my success. And how do you even gauge success when you're working with people that can just not do what you tell them, or do only a part of it, or pick and choose, and it's just hard to care and not be in control.
You are so right. And it's such a challenge for the younger physicians that I work with, the residents in training. They're the ones that get burned out. They're the ones that can't understand why the patient won't listen to them. What am I doing wrong? How can I approach this differently? What's wrong with that person? What am I misdiagnosing?
So there's a remarkable connection between what Father Sean just said and what I was going to say, with surgery being exactly the same thing, where, you know, the stakes are so high and everybody's counting on you and you got to do a good job, and then, you know, at the end of all of it you have to say, oh, you know, everything, you know, the patient did great, and like, did you do a good job? No. Like, we have to constantly have this tension between having such high stress to do a good job, and then at the same time being removed from that, and that tension creates, you mentioned the compassion fatigue, there's also an ego fatigue. And we almost have to have two brains, the one that, you know, attends to the person and cares and listens, and then the other one that's like this completely like rigid automaton that just does the procedure and then leaves and then goes back to be that nice person. And there's definitely a challenge there, and I want you guys to be, and anybody that interacts with surgeons, I want you guys to be very compassionate towards the surgeons.
Very nice.
That going back and forth between these two worlds is really challenging.
Very good. Very good.
We're going to thank Dr. Woroncow for her wonderful presentation.
Thank you.